So please relax. There's not going to be lots and lots of questions on renal physiology. There's going to be a bit of talk about it, but not too much, I hope. There's time at the end for questions. If there's anything you think of along the way, feel free to put it in the chat box and we'll talk about it, but there's certainly time at the end. So I'm going to talk about diuretics and basically how I sort of approach diuretics on ITU and why I think they're really important, actually. There's a tiny bit of physiology involved, but nothing too taxing. And there's even one histology slide, but I promise you it's nothing too major. So I think all presentations should start with sort of why do I care slide. So here goes. I want to give you kind of a typical example of a patient that you'll meet on ITU, really. So you're the ITU registrar overnight. You get a patient from theatres, they're sick, they're septic, they've been in theatres for hours, they've had lots of fluid. And despite that, they're coming back to you, they're on NORAD, adrenaline, some vasopressin. They land on ITU, you have a look at them and you think, okay, this patient needs more fluid, so you give a bolus. Blood pressure settles a bit, then you give a bit more. And throughout the night, that kind of goes on. You keep giving some crystalloid, and by the morning, the blood pressure's stabilised. You hand over to the day team. Your patient's still on, NORAD, adrenaline, vasopressin, but they're stable, their lactate's settling. You give yourself a pat on the back and you head off home, success, another life saved. And that's what we get, and that's absolutely fine. That's brilliant. That is what we need to do for these patients. But essentially, what happens next? So that NORAD's decreasing, but over the next few days, sort of what happens there? So typically, if all's going well, the vasoactive starts to decrease, and let's say, for example, this same patient, you're back 5 days later, you're on the unit, that patient's stabilised, they're off their vasopressin and adrenaline, and they're down sort of 10 mils of single strength. You review them, and the nurse says to you, the hands are puffy, they've got lots of sacral edema, their blood pressure's okay now, a MAP of 70, but they're still tubed, they're on 50-60%. What do you think about next? So we're not talking about kind of the acute bit. We're talking typically the patients that you meet, you might meet on the ward round 5 days down the line, and how you manage them. And the question I think I ask myself is, how am I going to get this patient off ITU and off all the clever machines and things? And you're left with someone on the vent that could be 20 litres positive even after a couple of days, and you may think I'm exaggerating, but this isn't unusual. We've seen pancreatics that end up on ICU 30 litres positive, having continually been aggressively resuscitated. And the problem is this fluid excess, it causes harm. And that's not to say there's anything wrong with what you're doing in terms of giving fluid, resuscitating patients. Patients need that fluid to resuscitate them. But it's important that we get rid of that fluid sort of early when it's no longer needed. Because otherwise, patients just swell up and get harm from that. But the problem is the kidneys get in the way, and I'll come back to that in a minute as to what I mean by that. This is just some of the examples of how fluid causes harm. One sec. Let me just second. So this is just some of the examples of how fluid causes harm to people. So there's lots and lots of different ways that excess fluid causes harm. And I want to draw sort of particular attention to like pulmonary edema. We see that lots, pleural effusions. And these are all like prolonged ventilation. Patients end up on a ventilator for longer periods of time, and we know that's bad for people. You get ileus, you get malabsorption, you get delirium, myocardial depression, atrial fibrillation. Wounds don't heal as well if you've got lots of edema there. You get more pressure ulcers, and kidneys, they don't like too much fluid either. And it might not make sense, but fluid excess, decreased renal blood flow, kidneys don't like too much fluid. And these are all problems caused by excess of fluid. So, it doesn't matter whether you're on the ward with a fluid overloaded patient with heart failure or ICU with an edematous patient, you should be looking out for this and acting on it to mitigate these harms. And this is just an example of some CTs that I pulled up sort of a few weeks ago when I was doing this talk. And literally all I did was have a look at the patients on ITU and look at their most recent CT scans. These are all different patients throughout their journey on ITU. And you can see nobody really escapes, unless you get through ITU in a couple of days, no one escapes without a bit of pulmonary edema. You can see all of these patients, they've all got varying size of effusions. And we end up spending weeks trying to wean down the ventilator, decrease the PEEP a bit, decrease the inspiratory pressure. And actually, I can't help but think, why don't we just speed things up, try and get some of this fluid off, and be a bit more aggressive in getting the fluid out of them, and give them a bit more lung tissue just to work with to get them off those vents. So coming back to why they get fluid overloaded, this is the sort of scheme to think about fluids and fluid stewardship. And this is, I think, a really important thing, certainly I feel it anyway. You've got that initial phase resuscitation, VR, where you've got an acutely unwell patient, they're getting large boluses of fluid, they're hypotensive or they're bleeding. And you're giving those large boluses just to kind of stabilize them. Then you've got the optimization phase, which is often in theatres, but often also when they get to ITU, where you're giving kind of more fine-tuned fluids, often using devices like echo, cardiac output monitors, Swan-Ganz catheters to kind of really get the fluid accurate that you're giving patients. Then you've got this stabilization or maintenance phase, which, if I'm honest, we're not very good at, but we're giving kind of the maintenance fluids for patients. And then really what I'm focusing on is this evacuation phase, the end phase, where the patients have had their resuscitation, they're stabilizing, they're getting better, but they've often got lots of interstitial fluid in all the wrong places, really, and it's how we get rid of that fluid. One second. So this is what goes wrong, really. So we're talking a little bit about the glycocalyx, and this is so all of our blood vessels, they're lined with this plasma matrix called the glycocalyx, this sort of hairy looking structure here within the blood vessel. And this is an electron micrograph of that. What that does, it sits there and helps keep proteins in the blood and out of the interstitial fluid. But it's this really delicate structure, and if it gets damaged, it allows fluids and proteins to leak out into the interstitial space, and that's where you get edema and sort of third spacing, if you like. And it's a bit of a design flaw, to be honest. I don't know why it's so delicate, but the problem is that almost anything that makes you sick damages that glycocalyx, just cleaves it off. General anesthesia, there's evidence that causes some damage to it. Just some transient hypotension causes damage to it. Obviously, septic shock causes lots of damage to it. And there's no real treatments to get it to recover quicker. Essentially, source control, sepsis management are the things that give it time to recover. But as soon as that glycocalyx is damaged, you just leak fluid out of your blood vessels. And it doesn't matter if it's protein-rich fluid you're giving a patient like HAS or Volplex, that fluid is just going to leak out. So the question next is, okay, so we've sorted out the sepsis, we've got source control, patient's edematous, but why don't we just wait? Why don't we just let the body get rid of the fluid just whenever it wants, really? Why should we be interfering with this? The good old kidneys have got this covered. If I drink too much water, I'll just pee it out, when the kidneys just do the same. And that's where we get on to, and I think it's quite interesting, a bit about how the kidneys evolved and what they do, really. Because I don't think we can just sit back and just let the kidneys do their job, because that's not really what the kidneys have evolved to do over the years. So I'll tell you a little bit about how we think the kidneys have sort of evolved into existence. So essentially, millions of years ago, we were fish in the sea, swimming around in salty water, and we started to evolve to go out onto land. Problem is, we've got glomerulus that's filtering, but as soon as we got out of the salty water, we didn't have access to salt and water, and would just dehydrate. So we then evolved this tubule to concentrate the salt and water. So, for example, if you've got an EGFR or a GFR, sorry, of this 125 mils per minute, you're going to make 125 mils a minute of ultrafiltrate. So that's your entire circulating volume is completely filtered every 40 minutes, which is incredible, Jasmine. It's brilliant. If you didn't have a nephron, you'd just pee out that 125 mils per minute. So as you're sat here, you'd be peeing 125 mils per minute. And unless you're drinking 125 mils per minute, you'd be dead long before that 40 minutes were up. So the kidneys, and the particular tubule, evolved to hold on to salt and water, let the waste out, so that we could get further away from the sea onto dry land, really. So that's all well and good, but then we evolved to become mammals. and we've still got these kidneys, and these are great. And as mammals, we tend to fall out of trees, we break our legs, we get impaled on things, we bleed. And the kidneys then detect this hypoperfusion from typically hypovolemic shock, and they do their thing. They hold on to the salt and water even more to try and keep our volume, and that works. That's brilliant. We eat something that gives us diarrhea and vomiting. Kidneys detect hypoperfusion. They do their thing. They hold on to salt and water. We get lost in the desert. Kidneys do their thing. Hold on to salt and water. All's good. Until we kind of get to modern life, when actually we get problems like our heart starts to fail, the kidneys detect hypoperfusion, and they say, well, all we've ever done is hold on to salt and water. And actually, we're not hypovolemic with our heart failure. We've just got a crappy heart and crappy cardiac output. So we end up getting edematous because the kidneys are holding on to that salt and water. It's the same with sepsis. Often we're not hypovolemic, certainly not total body water hypovolemic, but we've got a low cardiac output, so our kidneys hold on to salt and water. And again, we've got this same problem in the recovery phase. We've given patients tons of salty water in the form of Hartmann's, Plasmolite, saline, whatever, hopefully not saline. And our kidneys are just so, they're good at holding on to salt and water. They're not very good at getting rid of salt and water. So we end up left with these patients with this huge excess of water, huge excess of sodium chloride, and the kidneys are still struggling to get rid of it, because that's not what they're used to. They're getting used to sort of managing lots of potassium, really. So getting on, so how do I get past that? How do I get past the kidneys that, as far as they're concerned, we're sick, all they know is to hold on to salt and water? And this is how I do it. This is how I de-resuscitate patients. So I've said about why I think it's really important we do it. Now I'm going to talk about how I do it. So number one, you've got to think about, is your patient overloaded? Are they edematous? Do they have effusions? Are they, do they have excess fluid to get rid of? And I'll come on to that in the next sort of slide. Are they stable for fluid removal? This isn't the sort of thing that generally, a septic patient at least, lands on ITU. You don't want to be thinking about this in the first day or two. Some patients end up getting admitted because they're fluid overloaded, patients with heart failure, or patients from the ward that have had maybe too much aggressive resuscitation. But often patients, when they're septic, it's give a load of fluid, accept they need to stabilise, and a few days later, get rid of it. Step 3 is set this negative fluid balance target, and I'll talk about that a bit more, but it's really important that rather than just saying, I'm going to give 40 of furosemide, that you actually think, this is the target I'm going to aim for, I'm going to adjust the diuretics to get that target. And step 4, optimise those diuretics, and step 5 is reassess as you go along. The question 1 really is your patient fluid overloaded? So you look at this arterial line and you think, oh, there's a swing on that. And what I hear people say when there's a swing is, oh, that patient's dehydrated, or that patient needs more fluid. But that's not quite accurate, and it's really important that we get the phrases and the terms right. What that swing on an arterial line means is the patient might be fluid responsive, as in their cardiac output might improve by giving fluid. If you're still already perfusing your tissues and you're adequately perfusing, you've got blood going round and there's no signs of shock, then aiming for this kind of completely flat, no swing in the arterial line is probably giving too much fluid. And I appreciate there's not many people here today, but if you had an arterial line in now, being fit and healthy, breathing as you are, you would have a swing in your arterial line. Having a complete flat, no swing beyond the baseline arterial line, it's not normal, and it's probably a pathological state, actually. So you need to look at your patient and have a look for fluid overload, and the classic is, peripheral edema, but all of our patients are lying in bed, so often the feet actually don't get that edematous. So, and I see this missed all the time, we need to look at their stomach, in particular their sacrum, to look for pitting edema. And often it's the nurses that will turn around and say, oh, their hands are really swollen, we can't see their knuckles. And these are the signs that patients are fluid overloaded. Obviously things like chest x-rays, effusions, and things like that. And there are clever toys and gizmos and things like Vexus to look at fluid excess states. And I think they're really important, but we'll just sort of keep things simple for now. So as I say, the fluid tends to sink with gravity. It goes down to the sacrum. If you're just looking at your patient's feet, you might say, well, there's no extra edema on there, when actually it's all sat there down at the bottom of the bed where they're sat in their fluid, really. So this is what I often look for when I think about getting fluid out of patients. When they're stabilizing, have they got lots of sacral edema? Is it time for me to get rid of that? So the next question is, if you're happy they're overloaded, are they stable for deresuscitation? You know, if their NORAD's going up, if their vasoactives are going up, now's not the right time generally. If things are stable, you know, your MAF is stable, your NORAD's a static level, things are okay. And certainly if you've got a hypertensive patient with signs of fluid excess, then yeah, get the fluid off. Now's the time to get rid of it. Slightly controversial, should you be getting rid of fluid if the patient's still on any vasoactives? I think yes. If you're on a small dose of vasoactives, if you're into sort of single digits, I would be thinking about getting that fluid off. If your patient's stabilized and the NORAD or whatever it is on the way down, I think there's benefits of getting rid of that fluid sooner rather than later, really. I certainly don't think you have to wait until all the NORAD's off, because you know, if you've got a patient on propofol, you might never get that NORAD off, and I think you miss a lot of time. You can get rid of fluid off and make them better. Then you've got to set your negative fluid balance goal, and this is really important. As I say, it's not just a case of giving 40 of frusemide and waiting and seeing where you are the next day. You need to set that fluid balance goal and adjust your diuretics to get it. I think we often can aim more negative than we actually do. You know, I see kind of this number plucks out of the air of a litre negative. And basically my question would be, what's the worst that can happen if we get someone too negative? Well, the good news is, you know, you're in the right place, you're on ITU. Someone who shows signs of decreased cardiac output because of decreased preload, well, you're going to hear about it. You're going to have a nurse come to you and say, you know, we've had to go up on the NORAD, or the pressure's gone down, or the lactate's gone up. And it's great because it's an easy fix. You just give them some fluid back and the job's done, really. And I think we're a little bit too cautious sometimes with getting fluid off patients. I think we could, you know, probably aim more negative. I think there's a lot of benefit from aiming more negative, getting the fluid off more aggressively. And as I say, if you overdo it, then it's an easy fix. Just give them a bolus of fluid, and you know, if you aim for 2 to 3 litres negative, and you know, then you know, halfway through the shift, the nurse tells you that, well, their NORAD's gone up, or their base deficit's got a bit worse, then great, give them a little bit less diuretics, give them a 250 bolus of fluid, and you know, maybe rather than reaching that 3 litres negative, okay, you've only reached 2, but it's better than if you just, you know, aim for 1 and the patient had stayed solid as a rock sort of throughout, really. Just for context, so the most fluid I've got out of a patient in 24 hours was, I think it was about 9 litres, and the patient was on 60% high flow, gasping for breath, kind of at the start of the day, and you know, peri-intubation really, and by the next day they were on 4 litres nasal cannula, sort of playing on their phone. So, you know, in the right setting, we shouldn't be afraid to be aggressive and get rid of that fluid, really. So how do we do it? And I'm not going to focus too much on physiology here, because, well, I don't think anybody, apart from maybe me, I'm not even sure I always like it, but just to give you a bit of an idea about where these things work. So we'll talk about loop diuretics, which you all know, and I'm sure I'd be surprised if any doctor hasn't prescribed them. But there's lots of other diuretics that we use, or that I use, and I think we should be using as well. So you've got your potassium sparing diuretics like aldosterone antagonists. You've got your thiazide diuretics, and you've got your carbonic anhydrase inhibitors, which are kind of more useful, more relevant. But I'll tell you how I do it. So, and if you only you know, pay attention to one slide, this is probably the one that's going to be useful for you. So in terms of optimizing the diuretics, how I do it. So I've set my negative fluid balance, got a patient that's ready for deresuscitation. Start with frusemide, and you can't go very far wrong with frusemide, but it runs into problems. So I'd normally start with 20 or 40 milligrams of IV frusemide, just as a bolus, to see what happens. Give it 3 hours. If you haven't got that response in the first hour, double it and give it again, and keep doing that till you've got your desired effect. Do we give it as a bolus? Do we give it as an infusion? It probably doesn't matter. You get a higher peak dose with a bolus. but you need to give it frequently, probably at least 3 to 4 times a day. Because the problem is with frusemide, you give it, and after it wears off, you get this sort of salt-avid state where the kidney holds on to sodium. So you need to overcome that. So you could go with an infusion instead, and that's entirely reasonable. Maybe gives you a bit more control. But frusemide has its problems. You lose more water than sodium in the urine with frusemide. So you end up often getting a hypernatremia. The sodium just gradually creeps up over the following days. You also lose potassium, you also lose some magnesium, and you often have to replace that. So the potassium, first of all. So if I start a patient on frusemide, whether that's infusion or a 3 times a day regime, unless their potassium's high already, I'm often going to start by adding in some spironolactone, so really from the outset, really. Spiro 50 to 100 milligrams BD, and it takes about 2 days to kick in, so you do need to start that early. Hypernatremia, I'll talk about it a bit more in a second, but if they've already got higher sodium, then I'll start a thiazide straight off, because the side effect of a thiazide is hyponatremia. So why not combine that with frusemide, which side effects hypernatremia, and hopefully keep the sodium within the range you want to. I generally reach for indapamide. You can also reach for bendraflume thiazide, but indapamide is the one I think there's a little bit more evidence for. So essentially what the thiazides do, they try to keep the sodium in that tubule, so you wee out more sodium. And actually they overcome some of that sort of reflex sodium retention that you get post-frusemide. So essentially if I'm giving anything more than just a bolus dose of diuretics, if I'm thinking, you know, this patient's got a lot of fluid off to get over the next few days, I'm usually starting frusemide plus spironolactone plus or minus indapamide. Then you've got acetazolamide, which is sort of come a lot into favour recently because of a big New England Journal paper on heart failure and its use in heart failure. Essentially, again, another great diuretic, works to keep sodium in the tubule, so you get better sodium loss, and that's actually probably what we're aiming for, is rather than diuresis, is natriuresis, sodium loss in the urine. But the side effect of acetazolamide is you pee out your bicarb, so you get a metabolic acidosis. So actually what you need to do is, if your patient's got a high bicarbonate, and certainly high sodium, I'll end up reaching for the acetazolamide. So I've got some of the common problems that people tend to come to me with diuretics. These might answer some of the questions you've got, or these are some of the things that certainly I get asked, really. I get people say to me, you know, they've got an acute kidney injury, I can't give diuretics because diuretics are nephrotoxic. And let me stress, diuretics are not nephrotoxic, and I'll repeat that. Diuretics are not harmful for your kidney. If your patient's fluid overloaded and has venous congestion, impairing their kidney perfusion, diuretics can actually make that better. So venous congestion is nephrotoxic, so diuretics are good for that. If you give too much diuretics and you get dehydrated, dehydration is obviously bad for kidneys, but the diuretics themselves are not bad for kidneys. They are not nephrotoxic. They can cause things that cause harm to the kidneys, but you shouldn't be afraid to, you know, if a patient's creatinine has gone up and you think there's benefit of giving them diuretics, you shouldn't be afraid to give those diuretics. Essentially, they won't worsen your kidney function unless your patient's actually dehydrated and dry. I've given diuretics for a couple of days, and now the creatinine's going up. I should stop them and give fluid. So this is a really important one, and we see it more on the wards, but I have seen it fairly recently on ITU. So if you give a load of diuretics and get someone to pee out 2 litres of water, your creatinine will just hemoconcentrate. So the number will be higher, the concentration will be higher. That's because you've just concentrated it. And actually, there's a lot of evidence in heart failure patients that that's a good sign, that patients that get fluid off actually do well. So it's not to say, you know, if the creatinine's gone up by 20, I'm not worried at all. You know, if your creatinine doubles, then something else is going on and we need to sort of step back and think about that. But a small little bump in the creatinine of 20, after giving diuretics, I'm not interested at all. You know, if they're still got clinically overloaded, just crack on, get that fluid out them. The sodium is high, they're dehydrated. So this is a complicated one. And you know, you examine your patient. If they've still got lots of edema somewhere or everywhere, you still need to get rid of that. And it's how you manage that really. So again, thiazides will help you with that. But the problem with the high sodium is your kidneys think you're dying of thirst in a desert somewhere, so they'll hold on to lots of water. So actually, what you often need to do with these patients is give them just free water. If you can, just give them NG water to get their sodium back down to sort of 140. So it might be that you're giving someone 100 mils an hour of NG water, and your nurse might look at you a bit odd. But unless you get that sodium down, the kidneys are avidly going to try and hold on to as much water as possible because they think you're, you know, they think you're dying in a desert somewhere. So unless you get on top of that, you're never gonna win really. So give NG water, or you can give it peripherally via IV dextrose, but certainly enterally would be my favourite way of doing it. And you can carry on your diuretics at the same time or hold them, but until you get that sodium down, you're not going to make much progress in getting them de-resuscitated. My favourite phrase, I'm sorry Richard Porter isn't here to annoy me with this, but my patient is anuric and having a trial off the filter, I'll give some frusemide to kickstart the kidneys. So everyone says, whenever someone says kickstart the kidneys, you know, a glomerulus somewhere dies, God kills a nephron. I'll tell you why this is, well, certainly I think it's nonsense and there's no evidence to back it up. So where the blue arrow is where your frusemide is going to work on the tubule. And there's two sort of thoughts about how acute kidney injury happens and what happens within the kidney. There's this one that you get acute tubular necrosis. So the whole of the tubule is necrotic, has become ischemic due to, well, sort of cardiovascular collapse, I suppose. And the tubules are dead and died off, and they just need time to recover. So first off, if they're dead, giving frusemide to these dead tubules, so that's not going to make a difference, is it? It's not going to make those tubules magically recover or regrow any quicker. So that doesn't make any sense. The other theory I've heard is that the tubules are full of debris. Well, you know, maybe frusemide will work here for this half, but what are you going to do about the debris on the other half? So that's not going to make things recover any quicker. The other theory about acute kidney injury that I really like is there's this lovely paper called Acute Renal Success, where actually what they think happens is your tubules get hypoxic, and as I said at the start, your tubules are there concentrating your urine, stopping you from sort of peeing yourself to death with that 120, 125 mils a minute of filtration. And when they become ischemic, they can't concentrate the urine. And actually what happens is you get this vasoconstriction within the glomerulus, that the kidney basically shuts itself off to stop you peeing yourself to death. And if that's the case, again, giving diuretics working down here is not going to make your kidneys recover, not going to make this vasoconstriction stop any sooner. So it doesn't make any sense really giving diuretics to try and kickstart kidneys. And the other thing is you need the diuretics to get into the tubule anyway. So if you're not making any urine and you give diuretics, and that diuretic's not getting to where it needs to work anyway. So it doesn't make any sense to me. And the evidence backs that up as well. It doesn't, you know, given frusemide doesn't restart kidneys, it doesn't make things recover any better. So please stop it. Keep me happy. My patient's oliguric. You know, giving a diuretic means more urine output and better kidneys, right? Again, not necessarily. If your patient's overloaded, great, give them diuretics. But if you're just trying to make the urine output good to make a nurse happy, then you're kidding yourself, really. You know, what do we worry about in terms of putting a patient on a filter? It's, are they acidotic? Do they have electrolyte abnormalities? Are they uremic? Are they overloaded? Certainly frusemide will help with overload. So fine, if you're making some urine and you're worried your patient's overloaded, give them frusemide to make that to get that fluid off is going to help. But again, it's not going to make an acute kidney injury better any quicker. But my final one, why bother with all this nerdy kidney stuff? I could just give some albumin and just suck that fluid straight back into the circulation. That's why am I bothered about it? Well, again, I hope I've sort of explained that the kidneys are kind of designed to hold on to salt and water, and we really need to overcome that to de-resuscitate people. In terms of the albumin, I've got two problems with that. One, if your glycocalyx is still a mess and leaking out proteins, well, you put albumin in, that's just going to leak out into your interstitial space. And we seem to see that in studies as well. Giving albumin doesn't seem to do dramatic improvements in blood pressure. And my question there would be, have you ever given albumin and seen a dramatic increase in urine output? And I certainly haven't. Compare that to giving frusemide and getting an increase in the urine output. And then just for a little bit of maths, if you've got 5 litres of blood and lots of extracellular fluid, and your serum albumin is 20 grams per litre, so you've got 20 grams in each of those 5 litres. So you've got a total of 100 grams of albumin. If you give 100 mils of 20% HAS, you now got 5.1 litres of blood and an additional 20 grams of albumin. So that works out, if you do the maths on that, so 120 grams of albumin over 5.1 litres, you've got about 24 grams per litre of albumin then by giving that extra 100 mils of HAS. Alternatively, you give a diuretic, and if you get a patient a litre negative, you've now still got that 100 grams of albumin, but only 4 litres of blood. And actually, if you do the maths on that, you've actually got 24 grams per litre pulling the fluid in, compared to the 25 grams per litre pulling that fluid in. So, and actually, you've got rid of some fluid. So I think certainly I'd be reaching for frusemide before I reach for albumin, or something like that. So we just come to the end. Any questions that anyone would like to ask?
Okay.
Yes, Alex.
Hey, how are you? You all right?
Yeah, good. You're right.
Yeah, good. So just on that albumin thing, what's your opinion on giving albumin and frusemide?
Yeah, so good question. Hang on. I was going to hide this slide, but I can unhide it. So it doesn't work, is my understanding. Essentially, yeah, it doesn't seem to make much difference. I think it's an expensive way of giving albumin that doesn't seem to make much difference. The studies I've seen, studies I've seen don't seem to make much of a difference. I think if you were desperate, the theory is that frusemide is carried by albumin, so that should get to the kidneys better. The other theory is you're increasing the intravascular volume by giving albumin, but I'm not sure that's borne out in reality either. So I think, to be honest, I'm not saying an absolute no to it, but I would certainly be giving lots of frusemide, and I'd be into sort of the hundreds of milligrams of frusemide and adding in the other diuretics before I even thought about giving it, essentially, would be my view.
Thanks.
I will draw it to a close there, but I think the big things I want to stress is fluid excess causes harm. It causes bad things to patients. It leaves patients stuck on ventilators for longer. It makes mobility bad, trying to rehab patients. And I always think, if you've got a patient who's had critical illness, they've been, as sick as they've ever been in their life, and you're saying to them, I want you to get out of bed, but I want you to carry this extra 10 kilos of water with you. It's like we're on to sort of a losing battle to start with, really. So I think it's really important that we get that fluid off quickly and aggressively, actually. So I think it's important to spot overload. I think it's important that we set our daily goal and we aim for that, and that we're aggressive with that. And then certainly for me, frusemide, if it's just the one-off dose of frusemide, fine. But if you're thinking they've got lots of fluid to mobilize, often I start it with frusemide plus spiro plus indapamide plus or minus acetozolamide if they start getting that metabolic acidosis. And that's it, really. To give you an example of another patient on the ward, so this is on the renal ward. He's got ascites, got chronic kidney disease, got renal transplant, been in hospital for 28 days. And after I'd seen him, completely overloaded, massive abdomen of ascites. After a week with me, we'd managed to get him sort of 4 litres, 6 litres, litres and litres negative by the first week with me. And then by day 18, he was nearly 27 litres, at least on paper, negative, which, you know, appreciate there may be some inaccuracies in that, but you know, some patients are completely overloaded, and it's just important we get that fluid off when we can, really. Okay, I'll stop it there. Fran, you've got your hand up. Is that a question?
Yes, it is a question. You've said indapamide. So is indapamide your kind of your personal favourite thiazide diuretic that we should be choosing? Is there any benefit to choosing it above something else?
So, do I have a favourite diuretic? Wow, what a question.
He's already done it.
Tragically, probably I do. So I do reach for indapamide because there's probably slightly more evidence for it, but I don't have a strong feeling. If I'm on the ITU and a patient's got a high sodium, then indapamide, if we can get it easily. It depends sort of what's in the cupboard. Bendraflumethiazide, I think you have to give that twice daily. I don't think it's quite as long acting. You can also give something called metolazone, which we often give in renal, which is a really long acting diuretic. But no, I don't have a strong feeling about it. Indapamide, bendraflumethiazide, any thiazide diuretic, really.
Thank you.
So, hello everyone, and welcome to the Journal Club for the today. And I'm Dr. Pratibha, I'm one of the ITU fellow here at the Royal Infirmary. So, the paper that we are going to analyze today is IV vitamin C in adults with sepsis, a Bayesian reanalysis of a randomized control trial. I can hear your mind voices saying, why are we still discussing this? We all know the results, but this has been a very long-standing debate, and there are like millions of paper there which has been debating about whether it's good or not, whether it causes harm or not. So this is one good paper which has done a Bayesian reanalysis of the randomized control trial. So I think after end of the session, we'll be finally able to put a full stop to this debate. So a little into the background of why we started conducting these trials on vitamin C. We all know the definition of sepsis, but theoretically speaking, the antioxidant effects of vitamin C may mitigate this organ dysfunction. And because human bodies, we don't synthesize ascorbic acid, and vitamin C levels were generally very low in critically ill patients, they thought that this could probably be a good idea to give them vitamin C, and that might help them with their sepsis. There are so many randomized control trials, but everything has shown very inconsistent results. And this all started with one such trial by Marek et al., where they used something called as the Marek cocktail, which is a combination of vitamin C, hydrocortisone, and thiamine. And this was the initial study that just started with vitamin C, and the outcome was very surprising because it did reduce the mortality. It was 8.5% mortality in vitamin C group and a 40.4% mortality in the group which was not using vitamin C. But if you look at the study itself, it's not a randomized control trial. It has a very small sample size, and it was only a single center study. But this initiated all the other studies. There are n number of studies with all fancy names: citrus ALI study, vitamins, oranges trial, citrus trial. So the summary of all these trials, as you can see here, is that there is no big difference in the mortality, and even the time of vasopressors, there was no big improvement except for citrus ALI study, which included the acute lung injury patients. There was a mild improvement in the mortality, but even that was not very significant. But the last trial that's shown here is the LOVIT trial, which was conducted in 2022, which showed a shocking increase in mortality rather than no difference or good mortality rates. So the paper that we are going to see today is an analysis of this LOVIT trial. So I thought it would be a good idea to start with the LOVIT trial. This LOVIT is nothing but a lessening organ dysfunction with vitamin C trial. The clinical question that they took was, does high dose vitamin C improve survival or persistent organ dysfunction rates in septic patients? It was a multi-center study, blinded, randomized, placebo-controlled trial, well conducted. They conducted this study across 35 medical surgical ICUs in Canada, France, and New Zealand. And they calculated the sample size based on a 50% risk of death or organ dysfunction in the control group. And each group included initially 385 patients with a type 1 alpha error of 0.05. But then the COVID pandemic came, so they included more patients so that they can include even the patients with COVID-19. And the sample size increased to 863. About 400 and something in vitamin C and placebo group. So this study was one of the biggest landmark paper that they published, which was done over a period of 3 to 4 years. And they also had a follow-up of 6 months over phone call to all the patients included in the trial. The primary outcome was that it was a composite outcome. They were looking at 2 outcomes, death or persistent organ dysfunction. And the secondary outcome was death at 28 days, 6 months, and SOFA scores, biomarkers, and things like that. So the inclusion criteria are that all adults over 18 years of age, primary diagnosis of proven sepsis, those who are receiving vasopressors, and admitted to ICU less than 24 hours. The exclusion criteria were pregnancy, allergy to vitamin C, those who are already receiving open label vitamin C, and expected death or withdrawal within 48 hours. So the intervention group received vitamin C at a very high dose, 50 milligrams per kg, at a QDS dose for 4 days. And whereas the placebo group, they received only saline or 5% dextrose. And the use of thiamine and glucocorticoids were open label at the discretion of the clinician, those who wanted to use it and those who didn't want to use it. So if you look at the outcomes of this trial, the primary outcome was 44.5% increase in mortality compared to the placebo group who did not use vitamin C, which was only 38.5%. And even rest of the other bad things like vasopressor use, mechanical ventilation, renal replacement therapy, everything had a higher mortality risk compared to the placebo group. So the strengths of the study is that it had a really good sample size. It was randomized, blinded, well conducted. The compliance was excellent. Baseline characters were similar. They even calculated the baseline vitamin C levels in the blood for both the placebo group and the control group. And they used an intention to treat analysis. Whereas the limitations are that the antimicrobial appropriateness was not assessed. Different hospital settings used different antibiotics according to their protocol. And the generalizability may be impacted because all these patients were recruited from middle to high income countries and countries with low income countries where the sepsis is more common and more severe were not considered. And the primary outcome, like I said, is a composite outcome. They included both death and persistent organ dysfunction at 28 days. So is this trial a final nail in the coffin? I think it proves very clearly that yes, vitamin C is causing more mortality. That's what the study said. It resulted in higher risk of mortality or persistent organ dysfunction at 28 days. It was proved by end of the study. There's even a meta-analysis published in NAJM where they included all the trials that have come so far. Almost 1,500 citations and 40 plus randomized control trials were included in this meta-analysis. And they also came to a conclusion that vitamin C may decrease. There was very low evidence that vitamin C will decrease the mortality. Many of the trials had the risk of bias, and many of the published trials were not statistically significant. So they excluded all those trials, and then they came to a conclusion that vitamin C is not that great. But still, there were some citrus lovers who didn't want to give up on this. There were still more and more studies coming up. And finally, this Bayesian reanalysis was done. So Thomas Bayes invented this Bayes theorem almost 150 to 200 years ago. And all these days we have been just using that for analysis in engineering, astrophysics, and things like that. But in recent years, it's being included in the clinical trial because they think that a combination of Bayes analysis and our conventional statistical analysis gives really good results. So what is this Bayesian reanalysis? So it's a statistical paradigm that answers research questions about unknown parameters using the probability statements. So this allows both subjective and objective aspects of the knowledge to be measured. Sometimes we just have theories, hypotheses, and beliefs about a certain thing, and we might have some evidence in hand. When we combine both of this and then do an analysis, it's Bayesian reanalysis. So when I first read this paper, I had no idea about what Bayesian analysis for. So this slide is only for those who do not understand Bayesian analysis like me. So say, for example, we want to know the probability of rain tomorrow, and we have current weather observations in hand, and we also have the historical record of rain occurrences in the city. And using this complicated Bayes theorem equation as shown here, we can include how the probability of rain was in the past when the humidity was like this, and how is it now, and what will be the probability tomorrow. And when you include all these things into the equation, we'll be able to get probability of rain that will be possible. Obviously, this is not applicable to UK. I'm talking about rest of the world. So when you look at this Bayesian analysis, they keep talking about this term called prior. So there are two important priors that we should know about before we analyze the study: prior probability and the posterior probability. Prior probability is the degree of belief, what you think vitamin C would do, like is it good or bad, what you believe according to the knowledge that we have from the previous studies. Whereas the posterior probability is an upgraded or updated degree of belief, where we combine both the data that we have in hand, the evidence that we have, along with the belief. So in this study, they have used lots of priors, like the name suggests: neutral, skeptical, optimistic priors, pessimistic priors. For example, optimistic is when you believe that the interventional is beneficial. Pessimistic is when you believe the interventional is harmful. So they have collected all the data from the previous studies, and then they believe that, okay, this could be optimistic, and then they have kept one number, and then pessimistic, and then one number. So using all the priors, we are going to analyze it. So they've used something called as the Markov chain Monte Carlo method, which is a very complicated formula that similar to the one I showed you in the previous slides. So they perform Bayesian meta-analysis, including all the estimates from the LOVIT trial. And this report follows the reporting of Bayes used in the clinical. So there's a separate set of guidelines to be followed if you want to apply the Bayes theorem into clinical trials. And this paper has followed all the steps of these guidelines. So just to remind you what's risk ratio before we see the results. So risk ratio is the ratio between incidence of outcome with exposure and incidence of outcomes without exposure. If the risk ratio is more than 1, it means there's an increased risk of outcome. If it's equal to 1, there's no risk, and less than 1 is decreased risk of outcome. So just remember that risk ratio of more than 1 is bad. When you look at the results here, the third column, which is showing the 28-day mortality, the risk ratio is always. So when you look at the third column, the risk ratio for every prior, be it neutral, skeptical, optimistic, or whatever the kind of prior we have taken, the risk ratio is always more than 1, which means that it's bad. And when you look at the graph here, the white curve on the left side is the prior distribution, where we believe that vitamin C might or might not be good. It's lying on the side to the left of 1, which is might or might not be beneficial. But the blue curve is the actual posterior probability, where we know that it causes harm. It's lying well above the 1 mark, which shows that it's dangerous. So this post hoc Bayesian reanalysis is clearly showing us that there is a high risk of composite outcome of death or persistent organ dysfunction at 28 days when compared with the placebo. There's a high probability of harm was consistent across all the variety of prior beliefs, like you saw in the previous slide. Importantly, even when we thought that this could be optimistic also, it was still showing that it's bad. There are very minute limitations in the study. They have already considered optimistic prior, but they are saying that they did not consider a strongly optimistic prior, which could be a limitation, but I don't see it's a big deal. And they did use a composite endpoint, which can be a bias. And it still remains a possible that a clinically defined subgroup may be responsive to vitamin C is there, but this can be excluded only when we do an individual patient data meta-analysis, which is very tedious, and I don't think it's necessary given that so many studies have proven the fact that vitamin C is detrimental. So conclusion, I rest my case. I think there's a high probability of harm, and hence the implementation in settings where vitamin C is currently used should be considered. Thank you. Any questions or any further discussions?
Why do you think vitamin C actually is harmful?
Because in all the studies that were done, it is showing an increased risk of mortality.
Yeah. As in, what do you think is the reason that it is harmful? Is there like a theoretical pathology or anything behind this? Or?
I'm not really sure. Dr. Kishan, any thoughts?
Not to keep you not knowing.
No idea.
Excellent use of gifts.
I think for years, vitamin C has been sort of quoted as a panacea for infections, isn't it? And I think it was based, wasn't there some studies in the early 1900s of trying to reduce colds or something with vitamin C, and it became a really big hit. And I think one of the problems we have as human beings is we have bias towards things. So you're taught from David, from 8, 9 years old that you've got a cold, have some vitamin C.
Yeah.
So as you grow up, you think, oh, vitamin C must be good. And there's studies like this that basically, I mean, critically ill patients are different. They are totally different. And they've got this chronic inflammation going on. So there's probably some kind of fairly we should be giving until the next study saying it's good.
I don't.
They go round and round.
Yeah.
So Stan said something. I thought there was evidence that taking regular vitamin C results in reduction in duration of. Well, this is it. That was some of the studies done in the.
The results are very inconsistent, and even those studies which show a positive value are not very significant.
Yeah.
So that's why it should not be regularly implemented, but I think we can still take oranges every day.
Well, it's one of those things that it's like balanced diet, isn't it? Have a balanced diet rather than having just like all one thing.
If our child was sick, would you give them an orange? You think it's a bad idea?
You would, because there's not much vitamin C in orange. That's what we get. The vitamin C tablets you get, they've got massive vitamin C. So
It tastes good.
We see. I think there is a problem with ICU because what happens is it happens with steroids with Anan. What's his name?
Thiamine.
No, with steroid replacement. So basically, there's lots of studies in the sort of late 80s, early 90s that showed that patients who are critically ill have low steroid levels, or So the thought was, oh, we'll just replace it and they'll be better. Or we'll, in fact, let's take that inflammation, let's reduce the inflammation by giving them high dose steroids. It's that automatic reaction. If they haven't got something because of an illness, you just replace it and therefore they'll get better. But actually, quite often there's a reason why it's reduced. It may be suppressing some of these. The body's suppressing steroid production may be a good thing. So, it's like
excess vitamin C causes citric kidney stones. It's not harmless.
Okay.
That was a really good way of explaining Bayesian analysis.
Thank you.
People are thanking you.
Thank you all. Thank you, Fan. Thank you, Dr. Bell. Yeah.